Good evening, all, and we are live on YouTube. And please start.
Good evening, everyone. I'm Dr. Parul Jindal, and it is my absolute honor and privilege to serve as your moderator for this historic milestone. To officially commence today's celebration, I would like to welcome our patron, Dr. Tej Kaul Sir, our Society President, Dr. Naveen Malhotra Sir, General Secretary, Dr. Vishal Singla, immediate past President, Dr. Indrani Hemant Ma'am, eminent dignitaries, respected faculty members, and esteemed researchers and fellow delegates. A very warm evening to all of you. Today, we gather not just to celebrate an anniversary, but to honor the spirit of knowledge, scientific advancements, and patient safety that defines Research Society of Anesthesiology. Research, as we all know, is the backbone of clinical excellence. In the field of anesthesia, it transforms how we manage critical care, pain, and patient survival. To enlighten us further, we have our visionary leader today with us, and I now request Dr. Naveen Malhotra sir to deliver the welcome address and set the tone for this auspicious evening.
Respected seniors, founder members, fellow office bearers in the council, colleagues, dear postgraduate students, residents, and friends. I extend a very warm welcome to all of you on this very special occasion, the 42nd Foundation Day of Research Society of Anesthesiology. 42 years ago, very wise anesthesiologists shared their vision to come together and formed Research Society of Anesthesiology as a dedicated academic platform. What began as a small gathering to discuss scientific things, the efforts of our committed founder members over last 4 decades have grown up into a big tree with numerous branches across the country. We are leading the national community of researchers, teachers, and clinicians. Today, as I look around the screen, thoughts go to the members who formed this society and all the anesthesiologists who are practicing in all the nooks and corners, whether in the institutes or in the nursing homes. It is said true that the strength of society does not lie in its age, but in the continuity of the purpose which is carried forward by each generation of its member. We are lucky that we are serving the council. It's not privilege, but it's a duty. As we look back, we see our founders envisaged a platform where rigorous science and everyday clinical practice could meet. Over the years, Research Society of Anesthesiology has stayed true to its purpose. Our annual conferences, continued medical education programs, workshops, rational use of drugs, especially in current scenario. It is very, very important, and publication of that research, everything was done with perfection. I, on behalf of our council, thankfully acknowledge the founder members and the past presidents and the office bearers whose vision and tireless work brought us here where we stand today. Their contribution is the reason that we are having something worth celebrating today. Today, we are growing in membership from all across the country, conducting regular academic programs and publishing good quality journal. And none of this could have been possible without dedication of our committed executive committee of Research Society of Anesthesiology. Our national executive committee members, state council members, and office bearers of city and state branches, who quietly worked to make every event successful. As we embark upon towards our journey to Golden Jubilee, we have to deepen our research culture through structured mentorship for our postgraduates and young investigators, strengthen our outreach program for the youth, and expand our academic offerings to each and everyone, and continue to bridge the gap between clinical practice and research. and a deep sense of gratitude and thanks to all of you. This work is not a one person or one committee. It is the sum of 42 years where members have continuously worked day in and day out, year by year, decades by decades. So I thank each one of you, from patron, sir, to the zonal representative, who have worked for the success of our society. Today, as we celebrate our 42nd Foundation Day, let us reaffirm our commitment to the values on which RSAP was built, the scientific rigor and spirit where we serve the patients through better evidence-based anesthesiology. Thank you all and best wishes to each and every member on this Foundation Day. And yes, it is our 42nd year, but if we count it, the Foundation Day becomes 43rd because we were formed in 84. So that was our first day. So we are now 42 years old and we're celebrating our 43rd Foundation Day. Thank you very much. Long live Research Society of Anesthesiology. Jai Hind. Thank you.
Thank you, sir, for that warm and inspiring welcome. I would now like to call upon our revered patron, Dr. Kaul sir, to highlight the key milestones achieved since our inception and showcasing the incredible strides our society has made.
Sir, unmute please, sir.
Hello, hello. Am I audible?
Yes, sir, you're audible, sir.
Yes, sir. Audible, sir.
Thank you, Dr. Parl, for inviting me to talk about the Foundation Stone celebration of RSACP, rightly mentioned by Dr. Naveen as the 43rd Foundation Day. We have completed 42 years, but this is the 43rd Foundation Day. It's a great event. We need to celebrate it, and it is possible, it has been possible only because of the efforts of the previous office bearers, right from the first year of RSACP, now called as RSA. We are happy to be there, to be a part of RSA in 2026. We thank and we remember our leaders in the past, all past presidents, secretaries, and all governing council members in all the years. Dr. Naveen Malhotra has mentioned in a very subtle and in a very decent way that how RSA has come up to the present day status. It is a very well recognized association of anesthesiologists throughout the country, having a very respectable life membership and a very active governing council led by Dr. Naveen and Dr. Vishal to ensure that the society vibrates, keeps on teaching, keeps on learning, improving the research, making the guidelines, and helping each and every member of the society in whatever way we can as brethren and sisters. I again congratulate each and every member of RSA on this auspicious occasion and pray that our strength grows higher and higher every day. And all of us work hard and work sincerely to see that we become one of the leading anesthesia associations in the world. Thank you very much. Long live RSA. Thank you.
Thank you, sir, for your warm blessings. Every great milestone is built upon a foundation of enduring wisdom and proven institutional leadership. I now have an absolute honor of inviting our past president, Dr. Indrani Hemant ma'am, to enlighten us with her invaluable perspective.
Thank you, Parul. Respected Dr. Tej Kaul sir, Dr. Naveen Malhotra, Dr. Vishal Singla, and Dr. Sethi, and other dignitaries who are gathered over here. Dr. Sharma is here. My humble obeisance to all of you. It is a great privilege to be here today as a past president of Research Society of Anesthesiology on this Foundation Day. Actually, this Foundation Day reminds us that every scientific society begins with a dream, that knowledge shared is knowledge multiplied. And that is what RSA is doing. And that research ultimately translates into safer and a better patient care. Over the years, our society has nurtured a culture of learning and uh, and uh, not just a culture of learning, but also research, inspiring generations to contribute and practice evidence-based medicine. I could I couldn't agree more with what Dr. Tej Kaul and Dr. Naveen Mollatra already said about Research Society of Anesthesiology and how the society has grown leaps and bounds. As we celebrate today the Foundation Day, let us honor our founders not only by remembering their vision but by carrying it forward. Thank you, and I wish the Research Society of Anesthesiology a continued success in the years ahead. Thank you so much.
Thank you so much, ma'am. Due to some unavoidable circumstances, Dr. Anju Grewal ma'am could not join us. She sends her blessings and warm wishes to each and every person from RSCP. Now, behind every seamless execution of a collective vision stands a driving force of our society's operational and academic initiatives. So please welcome our energetic secretary, Dr. Vishal Singla, to address the gathering.
Very good evening, ma'am. Very good evening to all the esteemed members of the society, and a very warm welcome to all of you on this 42nd Foundation Day of the society. I would like to pay my gratitude to all the founder fathers, past presidents, past office bearers who worked hard for the society. It's my great privilege to stand in front of you and closely participating as secretary, having the privilege of closely observing the activities and the heartbeat of the society, its daily operations, and the growing family of members. Makes this milestone particularly special. Our society has been always involved in academics, research, and continuous life activities, which we would be continuing in the same spirit. Thank you very much, and long live Research Society of Anesthesiology.
Thank you, sir. And we all agree and we all support this thing that the backbone of any successful society lies in the meticulous management of its resources and sustainable growth. I now welcome our esteemed treasurer, Dr. Sunil Sethi, sir, to say a few words. Sunil, sir.
Yes, good evening. Sorry. Actually, I was in theatre. It is a very proud moment for me to be speaking in front of so many stalwarts of RSA and blessings of Dr. Kaul sir, Dr. S.V. Sharma sir, and the leadership of Dr. Naveen Malhotra is an exemplary thing. The society has progressed so much to this height, and we have done so much work for the society. I think this society has given me so many teachers, friends, and I am lucky to be part of it. That's what I want to say, and I congratulate all on Foundation Day of RSA. Thank you very much.
Thank you, sir. And starting with the proceedings now, it is time to ignite the spark of innovation by empowering the future torchbearers of our specialty. We proudly transition to the grand inauguration of Yuva Conclave 2.0, which is dedicated to nurturing our brilliant young anesthetists. So I now invite Dr. Tanveer Singh and Dr. Neha Sinha to take over.
Thank you so much, ma'am. Good evening, respected stalwarts of RSA. So, as we began last year, and we all know that every journey begins with a vision. So, last year, RSA Youth Conclave was born with one, that was to provide young anesthesiologists from all over the India a platform to express and obviously excel. And what followed was beyond our expectations. We witnessed brilliant presentations, thought-provoking discussions, inspiring stories, and most important, a vibrant community of young anesthesiologists who were eager to learn from one another. And I'm sure day in and out, we are already witnessing the power of the youth. We connected with the colleagues from every corner of the country, proving that talent knows no boundaries, and when they're given, especially when they're given the right platform. So today, with immense excitement and blessings of the seniors, we would like to launch the RSA Youth Conclave 2.0. This is just not another competition. It's a celebration of ideas, innovation, research, clinical excellence, communication, and eventually leadership. So, whether you're a resident taking your first steps in academia or a young consultant with experience to share, this stage belongs to you. So, we invite all our young anesthesiologists, 40 years of or less, who are working in medical colleges or corporate hospitals or our private practitioners to present, to speak about the topics that matter to them, whether academic or beyond. Let your voice be heard by the colleagues and mentors from all across the nation. If the first edition taught us anything, it is that the future of anesthesiology is bright and incredibly talented. And before I conclude, I would like to say that behind every successful initiative, there is someone who believes in the purpose. RSA Youth Conclave team sincerely thanks our program head, Dr. Naveen Malhotra, for envisioning the RSA Youth Conclave as more than just a competition. It is a platform where young anesthesiologists can find confidence, mentorship, recognition, and a national voice. His constant encouragement and trust has motivated each one of us to go ahead with this program and make every edition even better than the last one. We are also grateful to Dr. Vishal Singla sir for his unwavering support, and to all our national and state coordinators whose hard work has transformed this vision into reality. So, to every mentor who believes in young minds, and to every young anesthesiologist who dares to step forward, this platform is for you. We look forward to welcoming you to RSA Youth Conclave 2.0. I would now like to invite my state coordinator, Dr. Nitin Chaudhary, to say a few words.
A very good evening to everyone, and I congratulate everyone on the 42nd anniversary of RSA. It's indeed a pleasure to be a part of Youth Conclave once again. We had witnessed, magnificent amount of talent and great academics and non-academic talks in the last year's Youth Conclave. And we look forward to much more participation this time, looking forward to many more new talents and orators in this coming session. So we thank Naveen sir for giving this wonderful platform to all the young researchers and orators who are there and who want to participate in these activities. So it's a beautiful, wonderful platform for all of them. So looking forward to their active participation. Thank you, sir.
Thank you so much, sir.
So heartiest congratulations to the team, Youth Conclave. Thank you, Tanveer, Neha, and Nitin and Neha Mishra. And I am very sure that it will be a rocking event. God bless you all.
Thank you so much, sir. Thanks for continuously inspiring us, sir.
Thank you, sir. Thank you.
Congratulations, Neha and Dr. Tanveer. So to keep our community connected and scientifically updated, we must celebrate the power of professional journalism and literature. So join us as we officially launch the third edition of our prestigious newsletter, the RSA Times. Over to you, Dr. Nishant and Dr. Mayank Masant.
Thank you, Dr. Parul. Dr. Mayank?
Yes, Nishant.
Yeah, so it is an absolute honor, no doubt. It is an absolute honor that we have been chosen to be in charge of the newsletter, and it is a pleasure to launch the third edition of the RSA newsletter. So this newsletter has all the segments, and one thing that I'm actually very happy and particularly proud about for this edition is the interview that we have with our patron, the very respected Dr. Tej K. Kaul, in which he has mentioned about the history and how RSACP and how the JOCP came into existence. And he also has mentioned about some of his the goals and the people who were instrumental for the formation of RSA and RSACP. Uh, a lot of people have contributed to the RSA Times, and I'm grateful to each and every one of them. Another very innovative thing that I personally feel is that every issue has one statistical test that is discussed. And for the past two times, Dr. Abhijit has done a really wonderful job of discussing one test at a time. There are many other interesting segments. Dr. Mayank will like to add.
Thank you so much, Dr. Nishant. So every time when we sit together, we juggle our mind to find something important and recent for everybody to read. And as you all know, there are certain permanent segments and some which are variable. So this time, as you can see, it is monitoring that has been taken into consideration. So in monitoring aspect, we have covered up a difficult case which requires a tremendous amount of hemodynamic monitoring, and we have called it as Chakra View. Then we have got a very interesting section which is based upon the debate. So we have called Dwand. So in Dwand, debate is on whether BIS and entropy are important or not. So which one holds better? So in this way, we have juggled our mind to produce something every time in a new fashion. The backdrop remains the same, but the thought changes that helps us to provide it. And thank you so much, respected Dr. Kaul, sir, for providing us an input into how this particular fraternity of ours, where we are standing today, has started and has grown over a period of time. We are really thankful to respected Dr. Naveen Malhotra, sir, for inspiring us and for always guiding us. Thank you so much. And have a good read.
Thank you, Dr. Nishant and Dr. Mayank, for continuing to take the efforts to publish RSA Times, our quarterly newsletter, and which also includes the activities done by the association, like the RSA-sponsored CME at Tumkuru, highlights of the national conference at Indore, and also information about the forthcoming activities, including the 2027 RSA Con. Thank you. God bless you, Dr. Nishant and Dr. Mayank.
Thank you, sir.
Thank you, Dr.
Thank you, sir.
Nishant and Dr. Masand. So looking ahead, the horizon of our specialty promises even grander milestones and collaborative learning. Let us now turn our eyes to the future as we receive an exclusive curtain raiser, an official message from the team RSAPCon 2027. I now invite Dr. Monica Kohli ma'am, Dr. Tanmay Tiwari, and their team.
First of all, I would like to welcome and invite all of you to Lucknow. And in April 1st to 4th, we are holding our conference. And as you know, Lucknow is famous for its hospitality. And I assure you, we'll not, we assure you of the same. From first, we would be having two different halls in which we would like to do some life-saving skills for the interns and for the paramedics. From second and third is pure academics, which the venue would be Holiday Inn. Fourth would be our workshops, which is normal. The last day is the workshops, and that would be in the convention center. And we are expecting to have 8 workshops, which would be airway, simulation, hemodynamics, mechanical ventilation, and whatever is actually relevant for the residents. So I would once again like to invite you all for the conference, and we would be shortly sending you all invites. And whoever's wanting to come, please do reply soon so that we can start making our scientific program. Thank you.
Thank you so much, ma'am.
We are very sure that the team Lucknow will do a historic conference under the able leadership of Professor Monica Kohli and dear Dr. Tanmay Tiwari, and hope for a good academic content with a grand participation. Best wishes to all of you, and we are always at RSA National supporting. If anything is there, we are there for you.
नहीं, आपके support के बिना तो हो ही नहीं सकता. So definitely.
So with your permission, can we start with our webinar today?
Please.
So we now arrive at the intellectual core of today's webinar, designed to sharpen our clinical acumen and update our practices. Please silence your notification as we dive into this webinar and two high-caliber academic lectures to be delivered by masters of the craft. The chairperson for this session is Dr. Tej Kaul sir, the teacher of teachers. He needs no introduction. इनके बारे में कुछ कहना सूरज को दिया दिखाने के बराबर है. And he has recognized globally for expanding the academic reach and structural foundation of anesthesia in India. Our second chairperson today is Dr. Indrani Hemant Kumar ma'am, professor and head, GC member ISA National. She is affiliated with Symbiosis Medical College for Women at Pune. She is a past president of RSA National and president of state chapter of IPA. She is a current governing council member of ICA, SOA, PCC, and GC member of Association of Medical Consultants. She is the past president of ISM Mumbai, and she has received her Har Gobind Fellowship in Cardiac Anesthesia. Our next chairperson today is Dr. Monica Kohli ma'am. She is professor and head of the department KGMU. She is ex-state president UP chapter. Her area of interest is simulation and neuroanesthesia. With 65 publications, she is the organizing chairperson for RSACP 2027 and has organized several state, zonal and national conferences. Our next chairperson is Dr. Sarbari Swaika. She is professor and head at emergency medicine and is affiliated with D.Y. Patil Medical College Hospital, Pune. She has given B.R. Mittal oration delivered at RSAP. She is past president, given past president oration to ISA West Bengal, past EC member of IDA, past vice president of RSCP, and president of IPA Bengal. I welcome all of you and I request you to kindly introduce our two speakers today. May I request Dr. Tej Kaul sir to invite our speakers?
The speakers are who? I don't have their CV. I don't.
Sir, I've displayed it on the screen, sir.
Okay. Okay. I invite Dr. Anil Kumar. His current designation is professor at GVSM Medical College, Kanpur. He is the GC member of National RSACP and the general GC member of RSACM National. At present, he is affiliated to GSB Medical College, Kanpur. He has received innumerable awards and achievements, has innumerable publications in national and international journals. He has a chapter in the critical care of medicine, a chapter in Air Book of Anesthesiology, and he has a patent product by AM Bronco Trainer. I welcome Dr. Anil Kumar Verma to start the webinar.
Thank you very much, sir. First of all, good evening to all and all respected seniors and the leadership of the RSACP Society, because they are not just a leader, they are also mentor as well as my teacher. So my all regards to them. So let me start with my presentation. Is it visible?
Make it full screen, Dr. Anil. It's visible. Okay. Make it full screen. Thank you.
It's fine now. So yes. May I start now?
Yes, please.
Okay. My basic motive for this presentation to emphasize that no patient dies because of pathology. It is the biochemical environment which gets altered away from the normal status that kills the patient. And we have so many tools to assess the biochemical status of a patient in a critically or emergency, or even the critically ill patient who is being operated, to assess those patients. And we see the arterial blood gas. We all know and we all use it very frequently, day in and day out. But most of the time, the residents and doctors and even a few practitioners in the private sector, they do use this blood gas as a tool to assess the oxygenation, the acid base, the status, and the carbon dioxide of the patient. And many times when I asked few of the people whether you will use this ABG for the critically ill patient or not, they simply say the patient has no respiratory distress and no respiratory problems, so the ABG is not required. Where the ABG is not just for respiratory system, it also helps us to give information about so many systems in the body. So this presentation is focused to that, how to use this ABG to create a differential diagnosis. So this is a real case in my intensive care, and the story starts when my senior resident come to me with this blood gas, and she told that patient is absolutely fine. I said, how the patient is absolutely fine? She said the PO2 value is 127 and the patient is on CPAP. So pH is bit high, it is 7.5, and otherwise patient is opening, but patient is not opening eyes at all. So I said, okay, you sent me the blood gas, and when I saw this blood gas, I went to ICU and we just started discussing over this blood gas, and it took around 4 to 4.5 hours to complete our differential diagnosis, because it was a sort of a teaching session, so it took time. So this is a real blood gas scenario. When I started with this blood gas, I saw so these are the blood gas values. So if I see the blood gas values, the first of all finding what we notice, that is the pH value, and according to this pH value, this is an alkalemia. And if we apply the this mnemonic ROM, so this is primarily a respiratory component, because in the respiratory, the pH as well as carbon dioxide, they are going in the opposite direction. So we primarily call it respiratory. So the primary disorder is respiratory alkalemia. So whenever there is an alkalemia or acidemia or acidosis or alkalosis, because alkalemia is the primary finding, so we always go for the compensation. When we check for the compensation, we always see the counterpart, that is against the carbon dioxide, how is the value of the bicarbonate, and it is 13.7, where as per the compensation it should have been somewhere around 19.52, but it is even lesser than that. So it is a metabolic acidosis. There is a mixed picture, that is respiratory alkalosis with metabolic acidosis. So the finding of the patient, the present clinical condition of the patient, that patient is ideal body weight of 70, patient is on ventilator, CPAP, FiO2 50%, respiratory rate is 32, tidal volume generated is 440, pressure support 6, PEEP 6, and minute ventilation is somewhere around 14.08. So then we have seen the potassium value, the anion gap is raised. So let us go with this blood gas, because for the respiratory, so I'm skipping this slide because it will come again. So, and next slide, as we have seen, there is a metabolic, there is a over the compensation which was there, but it is over. So when we see, we have seen the blood gas, the anion gap is 16.3. So now we want to create a diagnosis. So only the anion gap is not with the cation as well as the anion, but many times when we see the corrected anion gap, the albumin value is also affecting this anion gap. So I took the albumin value, which was 24 and 24 gram per liter. It is per liter, and we calculated the anion gap came to be 20.30. Then with this anion gap, we calculate the delta ratio, and delta ratio is calculated to decide whether this is a high anion gap metabolic acidosis or normal anion gap metabolic acidosis, and my value came to 0.83. So according to this, the metabolic acidosis is high anion gap metabolic acidosis. So as per this mnemonics, so first the non-anion gap metabolic acidosis has gone out of picture, and in all the differentials which come for the high anion gap metabolic acidosis, there only the lactate value is shown high. Rest of the this differential has been ruled out. So there is no poisoning or no diabetic ketosis or acidosis or no ethanol poisoning, no salicylate. Only the lactate is the probability which is shown in this blood gas. It is 2.2. So it is a respiratory alkalosis with high anion gap metabolic acidosis. So in respiratory alkalosis, why it is called so? Because the PCO2 value is low. Now, what are the reasons of this PCO2 value low? That can be differential diagnosis can be made by the mnemonic CHAMP. And as per the CHAMP, the C stands for as per the CHAMP, their patient has or is of head injury. So it had contusion as well as subarachnoid hemorrhage. So one of the reasons that PCO2 is high because of the cerebral cerebral contusion and the component of the brain injury. Next, the hypoxia. We have PF index 240. So hypoxia is not the reason. Anxiety and pain. Patient was on fentanyl infusion, so pain was not the component, and patient was not awake, so should not be in the anxious state. Mechanical ventilation, when there is an excessive mechanical ventilation, but the patient was in CPAP, so whatever the rate was decided, that was by the patient's own. Progesterone and pregnancy, patient was a male. Salicylate and sepsis, yeah, salicylate poisoning was not there, but yes, total leukocyte count was 19,500 and PCT value was 2.8. So we can say that rest of the components are out, but on CPAP and with pressure support, patient is taking high respiratory rate. Now the main component which came out of this, the reason of this reduced PCO2 is the contusion as well as subarachnoid hemorrhage, and the sepsis are the main component. Now, as we go with the same finding, the previous, so the raised ICP as well as the sepsis are the two components which led to hyperventilation and low PCO2. Why this respiratory alkalosis is a problematic for this patient? Why it should be corrected? Because reduced cerebral blood flow by 2.5% for every 1 millimeter fall of partial pressure of carbon dioxide. Cardiac arrhythmias can be generated and low cardiac output is also there. Increased neuromuscular excitability and shift of hemoglobin dissociation curve to the left, so that it causes decreased release of oxygen at the tissue level. So though there is PO2 value is 240, but still the oxygen delivery to the tissue is reduced, and there is a hypoxia generated at tissue level, and which should not be there. So even PF ratio is 240, it is of no use. So rapid and slow correction or no correction is needed. Slow correction is needed because rapid will cause acidosis. And if we don't, no correction if compensated to metabolic acidosis unless less than 25 millimeter of mercury. Here the PCO2 value is 17 point, near about 17. So it has to be corrected. It is very much required. Now we have seen that patient is of high anion gap metabolic acidosis. Why? The increased production of lactate. First reason is shock. Yes, the patient was in shock. Patient was in noradrenaline. Heart failure because perfusion index was 0.45. So cardiac output was is reduced. Overall cardiac output, so considered to be in heart failure. Volume deficit. Yes, patient has a high IVC collapsibility. Thiamine deficiency. Patient was nutritionally compromised because patient was on bed for last 7 days and nutrition was not provided. Leukemia and lymphoma, no history. Metformin, alcohol, and cyanide, no history. So liver dysfunction, it was within normal limit. Renal dysfunction within normal limit, and excessive exercise, patient was bedridden. So what were the components which are basically responsible for this increased lactate? That is shock, heart failure, volume deficiency, and thiamine deficiency. So like this, we have created a differential diagnosis of increased lactates. So why the lactate should be corrected? Because it is a marker of critical illness, sepsis, shock, and trauma. Marker of tissue hypoxia, reduced oxygen delivery or utilization, and sustained high level leads to hemodynamic collapse. Why correction matters? Because lactate clearance is a guide of resuscitation by indicating restored blood flow and tissue oxygenation. So this is our blood gas. So we have taken the respiratory component as well as the metabolic component. Now PF index, it is 240. Is it normal? Yes, it is normal. It is adequate to deliver oxygen to the tissue, but still as per the definition of mild ARDS, it still comes into the mild ARDS state. So what can be the reason of this mild ARDS? Sepsis or pneumonia, accident found in accident found nothing. Trauma, there was no trauma other than head injury. Lung injury, no injury. Pulmonary fibrosis, X-ray was normal. Occupational, not exposed to the occupational hazards, and no medication was found. So ultimately the differential again comes here. The sepsis is the main factor which has created even this mild ARDS situation. So why it should be corrected? Because it signifies the presence of inefficient oxygen exchange and signifies the lung injury. So that means the lung injury is present, though it is in a very mild state, but still the lung is compromised. So the target correction, the PF index goes at more than 300. That means the lung is almost, the overall injury of the lung has been healed, and now the lung is in the normal situation, normal condition. So again, we go to this blood gas. The calcium has gone down. Now, what about the hypocalcemia? It should, if it is less than 1.15 millimole per liter, then it is considered a hypocalcemia, and we can use this mnemonic that CHAMPS: celiac disease, hypoparathyroid, alcoholism, malnutrition, pancreatitis, or sepsis. If you see all those reasons, the most common reason came here, that is the sepsis as well as the malnutrition are the most common factors which has caused this hypocalcemia. Now, the hypoparathyroid and hyperphosphatemia is not the primary reason, but because of the sepsis as well as the malnutrition state, they may be the secondary component which has created this hypocalcemia. So why hypocalcemia should be corrected? Because it causes reduced cardiac contractility and sustained hypotension. The target correction need to be correct unless it becomes more 1 millimole per liter. So now, what are the another finding? Chloride is normal, potassium is normal, sodium is low. It is 129 millimole. And side by side, the osmolality has also gone to 264. Most of the time, we miss this finding, the osmolality, to check the osmolality in blood gas, which is a very important finding. And if we go for osmolality, because there is a low osmolality as well as low sodium, so as per overall clinical history, we have found that this is in hypovolemic hyponatremia, and this hypovolemic hyponatremia is because the patient is of head injury. There was continuous mannitol infusions as well as diuretic has been given, and because nothing was given by mouth, and so overall salt intake was less even in this case. So hyponatremia, why it should be corrected? Because it causes cerebral edema, headache, confusion, seizures, high mortality and morbidity, indicating serious issue like failure of heart, liver, or kidney. So hyponatremia, whether it should be corrected rapid or slow correction, if it is an acute situation, that means the hyponatremia has been developed within 48 hours, then rapid correction can be given. But if it has taken in place in more than 48 hours, then slow correction has to be done. Otherwise, rapid infusion may cause demyelinating syndrome. Now, another component comes, that is glucose. It is somewhat normal. The hemoglobin is a bit low. The SO2 is almost near to normal. The bicarbonate is reduced. It is the part of metabolic acidosis. So metabolic acidosis, because bicarbonate is less than 24, gastrointestinal losses is there, no chronic kidney disease, blood urea was 34, creatinine was 1.1, diabetic ketoacidosis, RBC was normal, medication and toxin, no history, sepsis. Yes, again, the sepsis is the most is an important component which has created this metabolic acidosis. Why it should be corrected? Because it reduces the cardiac contractility, hyperkalemia, and promotes arrhythmia, impairs body response to catecholamines, and bicarbonate correction only if pH is less than 7.1, and the formula is there by which we can calculate the overall requirement of bicarbonate, and this deficit can be done. Rapid correction should never be done with the bicarbonate because it may cause paradoxical cellular acidosis. Now, as we have seen, the osmolality and the base deficit is there. Reduced osmolality, how it can create a problem to the patient? What can be the reason for this? SIADH, it was not present. Fluid retention, sepsis-induced cardiomyopathy as well, can be one reason, but renal function test is normal, so the CHF can be one reason that reduced osmolality has done. The sepsis-induced decreased liver function test, yes, serum protein was 2.4. Rest of the liver function was normal, within normal range. Hypothyroidism, acute short-term hypothyroidism can be there because of a sepsis as well as traumatic brain injury. It is not primary hypothyroidism, but it can be a secondary hypothyroidism. Adrenal insufficiency, as in case of a continuous infectious sepsis cycles, that may lead to adrenal suppression, and sepsis is definitely present. 19,500 is count. PCT is 2.8. Psychogenic polydipsia, patient was on E1 VT-M6, so psychogenic polydipsia has no role. Hyperglycemia, blood sugar was normal. Medications, diuretics, yes, definitely furosemide and mannitol has been given. So that may have caused the reduced osmolality. So these factors are out of picture, and these can be the most common reason what they have led to reduced osmolality. First of all, fluid retention because of CHF. Their sepsis-induced liver function test has gone down, and serum proteins are less. Sepsis-induced hypoparathyroidism, sepsis-induced adrenal insufficiency, and use of diuretics like furosemide and Why the osmolality management is quite important? Because it corrected osmolality prevents the soluble edema and prevents neurological damage like seizure, coma, and death can be corrected. So osmolality correction by how can it be done? First of all, free fluid has to be restricted. We can reduce the dose of diuretics, or we can stop so that free water loss can be reduced and replace the sodium as well as albumin. Not only simply sodium correction is required, but albumin is also needed to be corrected. So now if we collect all the red rows from previous slide, so from first slide it came that sepsis is the cause. In second slide, the lactates are raised. And third slide, the fluid retention, sepsis-induced reduced liver function test, hypothyroidism, and adrenaline insufficiency can be a reason. Next, the medication, that is diuretics, furosemide and mannitol, can be the reason. The sepsis again come into picture due to other problems present in the blood gas, reduced sodium intake, and the malnutrition or malabsorption, because patient was nothing taken by mouth and nutrition is required whenever patient is critically ill, and it is anticipated that patient has to be in the intensive care without having any nutritious product for the longer term than longer duration. So the IV nutrition has to be given in those cases. So next culprit we found, that is the use of diuretics, the mannitol and Lasix. So now this we have certain reasons why my patient was in the low situation. First of all, sepsis. I need to change my antibiotics, upgrade the antibiotics, the volume deficiency, fluid resuscitation, and stopping the diuretics. For the respiratory alkalosis, sedation with CPAP. That means if I sedate the patient more, either by adding another drug, or by increasing the dose of fentanyl. So, and just keep the patient on CPAP and CPAP or SIMV to control the overall respiratory rate as well as the minute ventilations. The metabolic acidosis can be corrected with the fluid resuscitation and with the use of inotropes. Hyponatremia, normal saline, and stopping diuretics. Hypoalbuminemia by replacing albumin, and thiamine deficiency by supplementation. So regular interval, I can keep on checking my ABG, TLC, PCT, and electrolytes. Like this, I can monitor my patient by adding these treatment or changing the treatment and stepping up further. So like this patient can be managed, and the ABG is helping me to create a differential diagnosis and monitor my treatment, how we can improve this patient. So that's all with this presentation. We can use ABG again as a tool to overall assess the patient systemically, not just for the respiratory system. Thank you very much.
Thank you, Dr. Anil.
Sorry, sir. Sir, please, sir.
Thank you, Dr. Anil Verma, for an excellent presentation of the interpretation of the ABG.
Sir.
How to interpret it, how to diagnose, how to start the treatment, how long, what are the causes, what can be the ultimate end. You have rightly said that when you went to see the patient and when you started discussing with the residents, it took 4.5 hours to talk to them and teach them. It has been really an eye-opener that how we should proceed in ABG interpretation, and not only the interpretation, how to treat such a patient. It was really a treat to hear to your lecture. Thank you very much. I hope, Dr. Indrani, you can just put some questions or add or anything, whatever you want to do, just for the speaker.
Excellent talk, Dr. Verma. It was very, you made it that much more interesting because you added some clinical scenarios and you gave all the possible, differentials to that scenario. And then you related that with the ABG. So that was, so interesting. And I'm sure the students who are listening to you must have really, really liked it, really understood everything about, the various types of, ABG problems which we face.
Thank you.
Really, really nice.
Thank you.
So, ma'am, we can take the questions at the end of this second lecture.
Absolutely. We'll take it in the end.
Right. Ma'am, can you please introduce our next speaker?
Yeah, it's my privilege to introduce Dr. Mayank. He is a senior consultant and a professor in the Department of Anesthesiology at Visesh Jupiter Hospital, Indore. He's a GC member of National Research Society of Anesthesiology and also the editor. He has special interest in onco-anesthesia and neuroanesthesia and critical care. The Vice President of ISA Madhya Pradesh, co-organizing chairperson of RSACP Con 2026, and he has about 24 publications. Over to you, Dr. Mayank, and he will be speaking on interpretation of IABP waveform. I think not many people are, they know about IABP, and I'm sure you will open everybody's eyes on how to interpret a waveform.
Thank you so much, ma'am. It's a real privilege to get introduced by you. Thank
Mayank,
you.
you are echoing. Are you on two devices?
You have two.
I have switched them off.
Okay. No, it's still echoing. So you have to completely switch off one.
Yeah, let me check. Yeah, it is. Now is it okay?
No, it's still echoing.
No, I think you leave the other instrument in another room and come. Better.
No, एक minute. I think I cancelled this. Parul, there is an indication by MM. You just remove that. MM.
Okay.
What is it?
MM, two capitals.
Right.
Yeah, you remove that.
Okay.
It is still not okay.
Yeah, I think now it is okay.
Now it's perfect.
Yeah,
It's not
fine.
Because it was in the hand, that is why.
Yeah. Okay.
Please go ahead, Dr. Mayank.
Yeah. Is it okay?
Yes.
Yeah.
Fine.
So the most important thing that I want to speak now is about intra-arterial blood pressure monitoring, and deliberately I have not included the name of the monitoring over here because we always face in the operation theater a very interesting scenario that whenever it is deadly required to have a blood pressure in place, we don't get the blood pressure reading when we are monitoring it by direct blood pressure monitoring. That is with non-invasive blood pressure monitoring. So at that exactly same point of time, you get to know the role of intra-arterial blood pressure monitoring. And it's a real privilege to get introduced by you, madam. And thank you so much for the lovely introduction. So intra-arterial blood pressure
Your
monitoring.
slides are not visible.
I have shared the screen. Yeah, just a minute. Let me check. Sure. Share entire screen. This share.
Yes.
Yeah. Yeah.
Yes. Now take it on the full screen, Mayank.
Yeah, I'm taking it from beginning. Yeah. Is it okay?
Yes, Mayank. Please
Yeah.
go ahead.
Excellent. Excellent.
Yeah. So now, if we go about it, so intra-arterial blood pressure monitoring is definitely stands out as the gold standard for blood pressure monitoring. Yes, we know with the current scenario in many of the centers in India, there are some technical expertise that are required for its placement and management. But once you are through with that particular speed breakers, you get to know the real importance of what it carries in toto for you in crucial cases, right? And the timely information that is given by this particular monitoring tool is extremely important in guiding you in many aspects which we are going to talk about. Now, what are the indications for arterial cannulations? First of all, it is repeated blood sampling when we are doing prolonged cases and we need ABG analysis, as Dr. Verma has spoken about recently in his excellent talk. Secondly, when there is failure of indirect arterial blood pressure management, example, when there is obesity, when there is burns, it provides us with a continuous real-time blood pressure monitoring. At the same time, it is a pharmacological measure to actually supplement our diagnostic information to take it further, to guide into fluid management, into our day-to-day variations in the blood pressure when the intestine or liver or lungs are being handled upon. Now, what is the basic principle? The basic principle is extremely simple. There is a cannula that is placed in one of the major arteries. From there is a tubing that is connected, which goes into the pressure transducer. And basically, a waveform is getting transmitted to this pressure transducer. Inside the pressure transducer, basically, the most important principle that is working for PG students, please remember it, it is the Wheatstone bridge formula that is working inside that pressure transducer. Afterwards, it is getting converted into electrical signal. This electrical signal is then being processed by Fourier analysis. Why? I'll tell you in further slides. Amplified and finally converted into a visual display for us. Now, the most important site that is being used is radial. Why? Because first of all, it is superficial. Secondly, it is easily accessible. Third, you can easily monitor if there is any complication occurring because of any our cannulation practices. And before proceeding with the radial arterial cannulation, we have to perform an Allen's test, which is a very simple test of first occlusion, then releasing one of the arteries, either radial or ulnar, and then releasing the ulnar artery to see ulnar artery to see whether there is redness coming in the limb or not, in the palms or not, and after that occluding it and again releasing the radial artery to see the collateral circulation. If the modified Allen's test is not working, then the problem is that we cannot cannulate that particular radial artery. Now, this is a very simple diagram to show how to go about it. The most important feature is to see the angulation is of 45 degrees. Afterwards, once you have penetrated the vessel where you will feel the loss of resistance, then you have to change the angle to 15 degrees and guide the catheter further. This particular step is extremely important to change the angulation of the needle. Otherwise, what will happen is you will just bypass that particular artery and will create a hematoma over there for further cannulations. The another technique that is being followed by many people is the transfixation technique. The transfixation technique specifies that the person has to deliberately, completely go through the artery, then revert back the cannula as shown in the figure 4, and then and then guide the cannula from 45 degrees to 15 degrees and put the cannula inside. Ultrasound imaging has reformed our current trend. 11 hertz is the exact probe that we should use, number one. Number two, we should always use out of plane technique. The reason is that the radial artery has got a very good hold in the, it has got a very good hold in the in between the ligaments, and it pulsates. So if you are going in plane technique, sometimes you can bypass the radial artery and go into the ligaments. In order to avoid that, if you go via out of the plane technique, you will be, the radial artery being superficially placed, you will directly hit onto the radial artery. You can very well see in this particular diagram, the vein structures are collaborating with the radial artery, which could be missed when we are using out of plane technique. In plane technique. Now, what are the alternative sites? The alternative sites are femoral, in which we always use Seldinger's technique, dorsalis pedis. Axillary artery, by many of them, in many of the researches, they have found out to be a place where there are least disturbances present. But because of aseptic, because of sepsis being the concern and sweat, axillary artery is not being utilized and it is not cannula visible. Now, what are the complications? The first important thing is hemorrhage. Second is distal ischemia, for which modified Allen's test is extremely important. Formation of pseudoaneurysm when we repeatedly puncture the artery or use transfixation technique. Arteriovenous fistulas, as I showed you, that the veins are present very nearly apart. Embolization, infection, and peripheral neuropathy. Now, these are some of the pictures that you could see. Over here, the finger is completely black. This is actually the formation of the ischemia for which the release incision has been given. These are pictures of pseudoaneurysms that have formed because of transfixation techniques, extremely common in dialysis patients and patients having problem with the thin arteries. Now, this is the physical principle that is being followed. What is a wave? A wave is a disturbance that travels through a medium, transferring energy, but it is not transferring matter. So now simplest wave is the sine wave. Now this sine wave is analyzed by what is called as the Fourier analysis. How this process is being analyzed. So there are complex waveforms which is being formed. The arterial waveform is not a simple sine wave, right? But according to the algorithm pattern, they have divided this particular arterial waveform into a sine wave pattern for which Wheatstone bridge formula applies, and that particular Wheatstone bridge formula gets transformed by Fourier analysis, and then it is processed to magnify it into an electrical signal. Now, what are the properties? First of all, two important points: frequency and damping coefficient are to be taken into consideration. Now, what is a natural frequency? Natural frequency means, suppose I'm giving you an example. We take a thread and hang a small ball over it and push it. The rapidity with which this particular thing is oscillating, that is the natural frequency of that particular ball and thread. Okay, now what is the damping coefficient? Damping coefficient are the surroundings, because this particular ball will slowly lose its momentum because of the frictional forces that are acting outside that particular system. So the damping coefficient actually determines that how fast this hanging ball will come into its normal place. That means it will determine the frictional forces that are acting to against the natural frequency to keep the system under control. Because if we leave the system out of control, then that particular system will oscillate at a very high speed without giving us any kind of analysis. Now, when we talk about the natural frequency, it is important for IBP system to have a high frequency, because if suppose the person goes into AF, atrial fibrillation, in spite of that, the arterial blood pressure monitor should have the tendency to manufacture that waveform and interpret what is actually going on. So 8 times is the fundamental frequency of the arterial waveform. Okay, so therefore, for a system to remain accurate, this line is very important. At heart rates of up to 180 beats per minute, its natural frequency must be 180 into 8 divided by 60, that is 24 hertz. This is 24 hertz is the figure to be remembered for purpose of the arterial blood pressure monitoring, because we take 180 beats per minute as the baseline. Now, what things can actually increase the natural frequency? By reducing the length of the cannula or tubing, we are coming up with what do you call small tubing sets. We are coming up with naturally small cannulas to cannulate with the advent of ultrasonography. We can reduce the compliance of the cannula by providing stiff tubings or diaphragm. Reducing the density, we always use normal line. We are not using dextrose. Increasing the diameter of the cannula or tubing, we should have a broad diameter cannula, and commercially available systems have a frequency of 200 hertz. Now, what is damping? Damping means the energy that is reducing the amplitude of the oscillation. Okay, so every system should be kept under control. So there should be a natural algorithm of damping which has been incorporated into the system, all monitors. So that is called as critical damping. But if there is over damping, that means the arterial waveform will have a slower amplitude, lower amplitude. If there is insufficient damping, the arterial waveform will have a higher amplitude. Now, on the left, you could see the arterial waveform have a higher amplitude. On the right, you could see that the arterial waveforms have lower amplitude. That means they are over damped. Now, factors that influence the over damping are one important point to be remembered. Over damping is present within the system. Under damping is present outside the system. This particular caveat is to be remembered. Friction in the fluid pathway. If the three-way stopcocks that we are placing are not properly placed, there is bubble or clot in the system. Vasospasm of the artery. narrow, long, or compliant tubing, or there are kinks in cannula or tubing. So over damping means outside system is being affected. Outside factors are affecting the monitoring. Under damping means inside factors are affecting. That means over damping. If outside factors are affecting, that is under damping. Fast flush technique. Now, this fast flush technique is employed in order to activate the algorithm within the system. Now, this is the most convenient process to determine the natural frequency as well as the damping coefficient. Okay. So, what is frequency? It is inversely proportional to the time. दो waves के बीच में जितना time है उसका inverse ले लो तो वो natural frequency है. Damping coefficient can be calculated mathematically, but it is usually determined graphically from the amplitude ratio. This is just for theoretical purpose. These algorithms are already loaded in our monitors, so they are being automatically read. But I am just explaining you to a system between the two wavelengths. This is the frequency being calculated, and damping coefficient is being calculated accordingly. Now, components are a bottle having a pressure bag. Then from there, the liquid comes into the pressure transducer or automatic flushing system, from where the cable goes into the monitor, and another cable from the arterial line which goes into the system. Now, this is one of the cannula that is very important. This is based upon the Seldinger's technique. This is based upon the cannula within the Stilett technique. This is another tube. So, as I said, this tubing before being attached should be completely thrown out of air, so that it is called as de-airing process in order to limit air embolism into the system. Intra-arterial cannula, fluid-filled tubing, transducer, and there is a flushing system that is being connected outside. Now, signal, processor, amplifier, and display are already there in the monitoring system. Correct? वो already है and it is loaded. Frequency and damping coefficient are also preloaded. This step is extremely important. Now, once we have employed the system, then we expose the transducer to the atmospheric pressure of 760 millimeters of mercury, and that reading is regarded as the zero reading for purpose of that particular amplitude. Okay. Now, at this particular point, when we are zeroing the system, is the leveling important? No. After zeroing also, we can level the system. What do you mean by leveling? Leveling means the pressure transducer is set at the level of the fourth intercostal space in the mid-axillary line, which corresponds roughly to RA or LA. If the transducer is low, what will happen? It will overread the BP. Okay, if the transducer is high, it will underread the BP. Now, this particular diagram is extremely important because you could see that if 0 is there and if we move the transducer above, that means it is above. So it is more than 760 millimeters of mercury, the transducer. If suppose it is +6, the BP will actually not be, if at 0 level, it is 120 by 80 millimeters of mercury that is being displayed. If we move the transducer to -6 level, the BP will come to be 150 by 90 millimeters of mercury. In a similar fashion, if this particular transducer is placed at +6 level, it will come down significantly. For every inch the transducer is above mid-chest level, there is a difference of 2 millimeters of mercury with the actual pressures. Now coming to the interpretation. Normal arterial pressure waveforms, the systolic. Now, the most important thing is that on the ECG, when you see the R wave, you have to see the systolic waveform. The upstroke should come immediately following the R wave. The upstroke should come immediately following the R wave. That point is important. That means your system is having a good frequency and good damping coefficient. Okay. What is the delay? It is the delay is of 180 milliseconds. First, there is an upstroke, followed by the downstroke. Dicrotic notch is important because this dicrotic notch determines the placement of intra-arterial blood pressure monitoring system. We have to synchronize this particular dicrotic notch if we are employing the intra-arterial blood pressure monitor into 1:1. Otherwise, there will be arrhythmias. After dicrotic notch, there is a downstroke which features that the ventricle is getting empty. Correct? Now, during the diastole, its decline during diastole after the ECG T wave and reaches nadir at the end diastole. After the T wave and end diastole. This is extremely important. As the pressure waves, this statement is again important. Once there is a pressure wave that are formed at every level, from the aorta to the subclavian to the peripheral arteries. As we go towards the periphery, the diameter of the vessel is getting reduced. So the upstroke will become steeper. That means the systolic peak will rise, the dicrotic notch will appear later, and at the same time, the diastolic wave becomes more prominent. इसका मतलब ये हुआ कि अगर एओर्टा की लेवल पर होगा तो उसका जो अप होगा वो सैंड ड्यून पैटर्न में होगा, और अगर हम रेडियल आर्टरी और फीमोरल आर्टरी जहां पर हम penetrate karke we measure the BP, the upstroke will be uphill pattern like a mountain peak. This you could very well see at the aortic arch. There is a sand dune pattern. In the femoral artery, the dicrotic notch is coming later and the upstroke is on the higher side. There are certain gradients which are extremely important, right? The nature of the operative procedure is important when choosing the appropriate site. What we are doing in cardiopulmonary bypass, sometimes we have to do both the monitoring, that is the radial artery as well as the femoral artery. In a similar fashion, when we are operating upon thoracic aneurysms and we are performing the procedures, we have to take a left-sided radial artery. That will actually provide us the complete gradient that is required. On a cardiopulmonary bypass, when we put the patient on the bypass, there is a process, right? First of all, on the initiation of the bypass, the mean radial artery pressure decreases and it remains less than the mean femoral artery pressure throughout the bypass period. So if you have used two arterial lines and you have to switch between the two arterial lines, you will be able to visualize that when you are monitoring the radial arterial pressure, it decreases faster than the femoral arterial pressure and throughout it remains less than the radial arterial pressure. 2 minutes post bypass, radial is less than femoral. 30 minutes post bypass, again it is lesser. Now, there are certain morphological features which are extremely important for diagnostic information. Let us come to the various procedures. Aortic stenosis. What will happen? Left ventricle is contracting against a closed valve. So what will happen? The pulse pressure will be narrow. So it will have a delayed upstroke. That is why it is called as pulsus tardus. There will be narrow pulse pressure. So it is called as pulsus parvus. Now see the figure number 1. That is pulsus parvus as well as tardus. It is going slowly up and slowly down. Although it is coming after the R wave and the peak arterial pressure is going further down because the flow is restricted. Coming to aortic regurgitation, there will be two. First of all, the aortic valve will close, band hoga. Vapis, there will be a regurgitation. So what will happen? Figure number 2. There will be two peaks. So it is called as bisference or double peak with a wider pulse pressure. In hypertrophic cardiomyopathy, there is a mid-systolic obstruction. So there is a spike. There are two dicrotic notches. So it is called as spike and dome pattern, which is mid-systolic obstruction. Now coming to systolic left ventricular failure, there will be pulsus alternans, alternating pressure amplitude. That is pulsus alternans. See over there, there's up and down. And cardiac tamponade, there will be pulsus paradoxus, exaggerated decrease in the systolic blood pressure during spontaneous inspiration. Now, Waveform analysis is a very important component that has come up to predict the volume responsiveness of the patient. Now, in the arterial blood pressure provides us a bedside initiation in the ICU, whether the patient is fluid responsive or not. And various algorithms have been developed in order to determine with a single radial arterial puncture by, I'm sorry to take the name, by Edwards, that is called as the flow track, in which stroke volume index, stroke volume variations, pulse pressure variability, all are incorporated into one, and we can predict with their measures that whether patients require fluid or not. Over there also, there is a gray zone, like 9 to 13%. If pressure variation is more than 13%, we see that we have to give fluid. When it is less than 9%, that means the patient is fluid adequate. But what happens between 9 to 13% is a matter still debatable, right? But why these pulse pressure variations occurs? It occurs because of the normal respiratory cycle. During inspiration, what will happen? The intrathoracic pressure and lung volume changes, and that actually determines the variability of the pulse pressure. So as you can see, it is 2 up in the normal inspiration and 3 down in the normal expiration. So there is a difference of 6 millimeters of mercury that is actually happening in this particular field. So this 6 millimeters of mercury difference that is acting is actually determining whether the fluid is inferior vena cava, which determines the preload, is actually transferring right amount of fluid into the RA to be delivered to the LV, and finally determining the cardiac output. And that determines the pulse pressure variation, and that determines the respiratory cycle. So stroke volume variation, pulse pressure variations are 2 very important index during fluid responsiveness. And that also determines the bedside when we say straight leg rising test or straight leg rising test, and there is a passive leg raising test that we employ. So without intra-arterial blood pressure monitoring, this particular thing is not possible. So please, the keywords that are to be remembered is Fourier analysis, Wheatstone bridge analysis, Wheatstone bridge formula inside the transducer, how the system will have a dicrotic notch, why dicrotic notch is important for intra-arterial blood pressure, for placement of intra-aortic balloon pump. When we are operating upon thoracic aneurysms, left side cannulation of radial artery is extremely important to determine it. In cardiopulmonary bypass, the radial arterial pressure will remain lower than the femoral pressure. With this particular presentation, I hope I have presented a ray of light to the people to think more about intra-arterial blood pressure monitoring and utilize it whenever needed, and don't compromise on monitoring. Thank you so much.
Fantastic lecture, Mayank. I think you not only touched on the theoretical aspect, but also you went into all the practical points, damping, over damping, under damping, what are the complications, and the various waveforms and various various disease like aortic regurgitation, what to do when you have a coarctation, which side you have to take, and all those practical tips you have given, and fantastic lecture.
Thank you so much. Thank you.
Yeah, it was a really good lecture.
Thank you so much.
For a
It is a
moment, I
real
thought,
pleasure to
you
hear
were
it
going
from
to
you.
talk on intra-aortic blood pressure. That's why I said not many people, knew or know about intra-aortic blood pressure. But well, it's even better that you spoke about intra-arterial blood pressure, because the students will benefit a lot out of this lecture. Thank you so much for a really wonderful lecture. And I request actually other chairpersons also to give their opinion.
Very nice presentation, Dr. Mayank. It has been really very informative.
Thank you so much.
I would suggest that for all the residents who start cannulating the radial artery for the intra-arterial blood pressure monitoring, they should first listen and watch your lecture and then proceed.
Yes,
without
Thank you, sir.
None of the residents should proceed to use this methodology for.
Thank you so much. Thank you so much, sir.
Very nice. Very, very, very fine. Dr. Indrani has already mentioned everything, and it is excellent. Excellent. Always Thank you. Thank you very much.
Do we have any questions from the audience? I can just see praise for all the beautiful lectures you both have taken. So if anyone wants to add to something, we have so many learned teachers here. Would somebody like to add on to it or want to give their suggestion or share their experience?
I would suggest the organizers, Dr. Paul, yourself and others, that in future also lectures like these should be kept in the webinar, which are practical, which are important for the beginners, and even very important for people who practice it daily to improve their techniques and their methodology and learn how to interpret the things. Both the speakers have been very, very good and very informative and very impressive. Thank you. Thank you very much for arranging this academic webinar. And in future also, topics like these should be kept rather than other things. Thank you.
I just want to add one more thing. It was something which I have seen. It was a case of single ventricle. And we had a child, for whom it was very difficult to take an arterial puncture. With great difficulty, finally, we got the arterial puncture. And the case went on. I think they did a PA banding or something like that. And in the post-operative period, the child, which was 3 months, no, one month old child, developed gangrene of the fingers. And then immediately the arterial line was pulled out, and then stellate ganglion block was given. That did not help. Then vasodilators were given, did not help. Then finally the child had to lose, small the fingers and all that. And then finally, even that, after the amputation, they found that the child had only one artery. I think it was the radial artery. The ulnar reperfusion was not there. So the child had gangrene of that hand. And of course, they went to the court, and it didn't work. They went to the court. And so the importance of Allen's test while before cannulating is, I mean, we have to press on this, that Allen's test has to be done. Of course, doing that Allen's test in that 1-month-old child would not have been easy. But then, at least in adults, when we are, doing arterial puncture, Allen's test is very important. And even in an examination, when you know that you're doing, supposing you have a case of lung or a liver or, a supra-major case, then I'm sure in your general examination, you have to mention Allen's test, because you will be taking an arterial line. You'll be stepping up your monitoring. So that is what I wanted to tell all the residents.
Thank you so much, madam.
That is why I said, madam, that anybody, all residents who start thinking to put an arterial line must hear and watch Dr. Mayank's lecture first.
Thank you.
Very simple points, but very important. Very important.
True, sir.
Madam, just a question. Like, sorry. Dr. Parul, please go ahead.
Yeah. We have Dr. Tarlika ma'am with us. Ma'am, would you unmute yourself and address us? Tarlika ma'am, are you there? I think there's some problem. Dr. Naveen sir, please sir, your thoughts.
It was excellent listening to both dear Anil and Mayank. And thank you, Parul, for organizing this event. And thank you, Vishal and Tanveer, Neha, everybody. And thank you to the very respected chairpersons, Dr. Kaul, Dr. Indrani, and Madam Swaika. So I think we are on time, 6 to 7:30, bang. So it's time to say bye for now and see you for the next academic event in a couple of weeks.
And a
Thank you
memorable
very much.
foundation day, sir.
Hanji, madam.
Memorable foundation day.
Yeah, it's a well planned, memorable foundation day, and I know the background efforts which have been put in by the team. God bless you all. Thank you very much. Long live RSA. Jai Hind.
Long live RSA. Long live.
Long live RSA.